Hello and welcome. Welcome today. We're very, very excited for today's session on mobile response and stabilization services, the Learning Community virtual series. For those of you who haven't joined us before, we're really happy that you're joining us today. My name is Liz Manley. I'm a senior advisor for health and behavioral policy at the Innovations Institute at University of Connecticut School of Social Work, and we're really, really happy that you're joining us today. This is our final session. We've been working at this for about a year. For folks who have joined us in all the sessions, you know that we have actually taken a look at many of the states that are really working intensively on mobile response and stabilization. And for those of you who have joined us before, you know that some of the folks who are joining us today are pretty familiar faces in the world of mobile response and stabilization. So how lucky am I to be able to actually engage in a conversation about what mobile is, what it does, and how do we actually help states move forward, communities move forward in engaging this real customization of what mobile response and stabilization is, what it does, and how it can help. So let's start at the beginning. Before I move really deep into my part of the conversation, I think it'd be really helpful to know who's on the panel today. So I introduced myself. I would really love it if our panel introduced themselves. So Shane, if you want to just unmute and say hello, that'd be great.
Happily. Hello, everyone. My name is Shane McDonald. My pronouns are they, them, and theirs. And I'm a youth program specialist with Youth Move National, which, just to put it briefly, is a youth-driven, chapter-based nonprofit that works to uplift the lived experiences of youth and young adults to inform meaningful change across youth-serving systems. I'm located in Massachusetts. I'm queer and trans, as well as a trauma survivor with roots in direct peer support and youth-run peer program development, as well as within the overall recovery movement built on lived experience. And I am so grateful to be here.
Thank you, Shane. Hazelyn, you want to say hello?
Good afternoon, everyone. I'm delighted to be with you again and to be a part of this learning community. My name is Hazelyn Pilgrim. I'm the Executive Director of Family Support Organization of Essex County in New Jersey.
Thank you, Hazelyn. Hey, Shamika, you want to say hello from Oklahoma?
Hello from Oklahoma. I'm Shamika Williams. I'm the Director of Children, Youth, and Family Services at the Department of Mental Health and Substance Abuse Services, and I'm extremely glad to be here today.
And last, but certainly not least, Tim, you want to say hello?
Good afternoon, everybody. Thanks for having me. Tim Marshall. I recently retired from the Department of Children and Families here in Connecticut, back on temporary assignment with them, and also have been working with Innovations Institute at UConn, just on helping MRSS and also some other system of care activities. So it's great to be here on the final day of this opportunity.
Thank you, Tim. So it's a very special day for me because I've started this work with other states when I was still the Assistant Commissioner in New Jersey's Children's System of Care in 2016 or 15, and Tim and Shamika actually joined and came to New Jersey for some of this work. So we've been at it for a long time and we'll continue to be at it for I think until all 50 states, all of our territories have access to mobile response and stabilization, because it's such an important component of a children's crisis continuum. And so let me just make sure that folks are grounded in what we're talking about. So the first part of what mobile response and stabilization is it is a just go mentality. When a parent, caregiver, young person themselves pick up the phone and ask for help, then we just go. We don't debate, we don't define the crisis. That crisis is defined by the individuals who call, right, for assistance. And by that, I mean, and you'll hear from both Shane and Hazelyn on the real importance of understanding why this first step is so incredibly important in the work. Two, that it's a non-co-responder model, which means that we're partners and work with and embrace the work of law enforcement, but they are not co-responders in this model. They're partners in other ways in the work, but not in the way in which law enforcement is going to join us to help in de-escalation of children. We'll talk a bit about that today, I think, around why it's so important to understand the role of law enforcement when it comes to the children's crisis continuum. Three, it's really important to understand that all of what we're talking about today is really about in-home supports and services, connections to the community. And although that there are parts of the continuum that have the connection to higher intensities of service, even 24-hour beds and all kinds of other things. When we talk about mobile response and stabilization, and we're talking about stabilization services, for the purposes of today, we're really focused on what happens in the home, schools, and communities. And we're happy to talk about those other parts of the continuum, which we think are important, but that's not necessarily the focus of today's discussion. We also want to talk about how do you ensure success? Like, what is it that happened? And this is why you're going to hear about 3 state examples. Certainly, you're going to hear about Connecticut and Oklahoma's example, so important. And you'll hear a little bit about New Jersey's example, because these are 3 states that have embraced this work, continue to move the work forward. And by that, I mean engaging in new populations and new supports across the continuum. And so you'll hear about these models. And the last thing I want to say before I hand it over to the panel to take over is that we are embracing all questions today. Today is a time for you to send out all questions you might have. We're happy to try and tackle them. There are no better group of people to try and do that than the folks who've joined us today. So without further ado, I'm going to hand over to our esteemed panel to get us moving. So Shane, I'm going to hand to you and let you go.
Wonderful. Thank you, Liz. Again, my name is Shane McDonald. I am a youth program specialist with Youth Move National, and I could not be more grateful to be here. My stake in these conversations is absolutely both professional and personal. I myself have experienced crisis on several occasions as a young adult, and through my interactions with systems and supports, I didn't really feel like I was participating or had ownership of the process. I felt like, as with the crises themselves, unfortunately, that all of these things were happening to me. So everything I'm going to speak on today is really meant to be in service of shifting that narrative for other youth going through these services. As with all of my work with Youth Move National, I envision a future where young people are valued as empowered leaders, advocates, and designers of systems and communities that are built for all youth to thrive. And this is particularly important when thinking about young people with historically excluded identities and how these systems, again, historically and even currently, continue to harm and disenfranchise them. Today, my focus will be on youth-defined crisis, the role of peer support, and of course, the role of police, including those co-responder models. So first and foremost, right, uplifting the idea that crisis should be defined by the young person going through it. The reality or the belief that it is impossible to be heard and understood is often a big part of a young person's experience of crisis. And let's be honest, experience of the world in general. Being present with and holding space for youth across each phase of mobile response and stabilization services should involve prioritizing their deconstruction and definition of the crisis and what the ideal path forward looks like to them. And I want to say, there's been a lot of talk about the needs of the family, right, quote unquote, within these conversations. And I think that that's so, so important. However, it's also important to know that unfortunately, in many cases, the needs of the family can tend to dissolve and focus more on serving the concerns, definitions, desires of the parent or caregiver, sometimes over that young person going through the crisis, right? It is absolutely real and valid that crisis situations for youth have a significant impact on the parent or caregiver or whole family unit at large, right? It is also understandable that parents and caregivers want to reclaim that agency and autonomy from providers in a similar way. However, that doesn't mean that the young person's voice, choice, and definition of the crisis should be in any way treated as secondary. It's also, and this is just a little nuance, right? Think about the potential that the parent or caregiver on a rare occasion could be contributing to the crisis itself, right? As an example, think about LGBTQ2S+ youth with parents who might not accept them and bringing them, and that might maybe bringing them to a place of crisis or being a major factor in it. What consequences could come from prioritizing those caregivers' definitions of the crisis and desired approaches to address it? Just something to think about. And this is not at all to take away from the efforts of parents and caregivers in these conversations. These are just things that I feel are important to note as someone who myself has experienced parental involvement during times of crisis as a young person in ways that created a lot of harm for me. And I want to ensure that lived experience, that efforts by youth and families or parents and caregivers within these systems are working in partnership and collaboration, right? And not in any way in contention with each other. And I think in my work, at least in this area so far, that's absolutely been the case. case. And I am so grateful to have both perspectives present for this conversation. And at the end of the day, and this is a nice transition into my next point, which is the value of peer support, lived experiences should be at the forefront of informing these efforts at every level, both from the consumer user end as well as from the provider designer end. So now the role of peer support. Peer support should be incorporated into every facet of crisis response. People with firsthand lived experiences within these systems and services know what's working, what's not working, and what changes need to happen because they've been through it themselves. Peer support means that people who share aspects of identity or lived experience can offer culturally and socially responsive, accessible, and unique non-traditional and non-clinical forms of mental health and crisis support. These can include culturally responsive mentorship and direct support, non-coercive check-ins, trauma-informed de-escalation and rapid response work, of course, information about a young person's rights while in restrictive treatment environments, advocacy and support for getting their voices heard, and of course, self-determined needs met, support at meetings, appointments, brainstorming, problem-solving skills, and even locating essential resources to address basic needs that could be contributing to that experience of crises. Peer supports act as partners, facilitators, or bridgers to connect to healing resources young people are comfortable using and develop their ability and capacity to self-advocate. The peer support model generally rejects or moves away from more coercive or punitive approaches, and that includes restrictive treatment environments like locked hospital units, right, in favor of therapeutic peer support practices and more community-based programs and resources. So they're really essential to the goal of interrupting care pathways in that path to more intensive restricted treatment settings. Peer support is also essential to that first point of youth-defined crisis. Rather than objectifying or maybe naming the crisis experience in relation to maybe provider-defined narratives, youth peer supports can begin to explore the subjective experience of the young person in crisis while offering snippets of their own lived experiences of navigating crisis to the relationship. And out of this shared dynamic in which a greater sense of trust is built, the crisis can really be an opportunity to create new meaning and offer young people mutually respectful relationships in which extreme emotional distress and experiences of crises can be explored and self-defined along with the path forward from there. Caregivers and adults involved in a young person's crisis, I believe, should absolutely also receive peer support and resources. But something I want to note is that I believe that they should be distinct and separate from those resources and spaces provided to the young person themselves. So really ensuring that parent, family peer support and youth peer support are provided individually, but in tandem. That way, both parties get support from a peer with similar lived experience and no narrative overtakes the other, right? They're both held as valid and important. And my last point, which is about the use of law enforcement in these co-responder models. And just to preface, I'm going to be a little bold here, so stay with me. Here is the hard truth. The mental health system grows alongside systems of oppression. Capitalism, white supremacy, imperialism all exist within its roots and unfortunately continue to influence the system even now. And these white-dominated, often violent, coercive, and unaccountable ideals disproportionately harm youth of color, LGBTQ2S+, and disabled youth. Ultimately, right, I envision a world where we are successful in dismantling all of these systems of oppression that cause so much of the emotional distress and inner turmoil, the trauma that so very often leads to a place of crisis. I also envision a world where mental health care, including mobile response and stabilization services, are rooted in community, equity, and justice. So all in all, an anti-oppressive or justice-oriented approach to mobile response and stabilization services, as with all mental health services, must also be anti-carceral. This means moving away from practices and protocols that perpetuate the idea that punishment, policing, surveillance, criminalization, and incarceration uphold goodness and safety. These carceral practices are ingrained everywhere, in institutions, industries, even in our interpersonal relationships and the ways that we treat ourselves and understand our experiences. And again, these carceral tactics have been unfortunately extended into and perpetuated by the mental health system. This means that they are part of the many systems that have historically functioned to contain people, take away their agency and control, offer surveillance, isolate them from their communities, and limit their freedom. So first and foremost, this hopefully makes it clear that absolutely any police involvement, even in a co-responder model, can lead to these outcomes and should not be engaged in mobile crisis response and stabilization services. And second, mobile response and stabilization service providers and system designers need not only to unpack all involvement with and reliance on the police and carceral institutions, including those locked, restrictive psychiatric units and settings, right? All of us, including stakeholders in these conversations, must also delve into how we embody carceral logic ourselves, both in our work and in our everyday lives. This exploration can also lead us to uncover how we are taught to fear and act in carceral ways from our training institutions, associations, and again, unfortunately, even within the mental health system. It's important that social workers and any other mobile response and stabilization service providers do not fall into a similar role. This is where that pushback comes with the like replace the cops with social workers argument, right? Is the fear that it's going to be more of the same disguised as something else. So again, and I believe that this is important regardless of age and identity, particularly for young people with historically excluded identities, Black, Indigenous, and youth of color, disabled youth, LGBTQ2S+ youth who have been and are continuing to be disproportionately harmed by these systems, particularly police. It is imperative to approach system reform and design through an anti-carceral, justice-oriented, peer-led, and trauma-informed, community-focused lens. And I'll close out by saying that these co-response models are absolutely a means of harm reduction, but in all, I'm adamant that absolutely no police involvement unless absolutely necessary should be the standard. So thank you all again so much for being here. I believe I'm passing it back to you, Liz.
Thank you, Shane. Thank you. Thank you. Listen, I think that this is a really complicated conversation, right? And I appreciate you putting it out there. What we are so hopeful about is that mobile response and stabilization is a reframing and rethinking about how do we actually provide support when individuals need it, at the time they need it, the duration they need it, in the way that they need it. And in order to do that, it's incredibly important for professionals to understand all the things that you just shared with us. We're happy to have more conversations about this later, and I see that the chat is lighting up, so we're gonna get to those later, I promise you. But in the meantime, Hazel, and I'm wondering if you could take the lead in sharing the family's perspective. That'd be great.
Well, certainly. First, I want to just acknowledge my co-panelist Shane for the incredible and insightful comments that you offered, certainly giving us a lot of food for thought around creating a vision for the future that is rooted in justice and equity for all, and that is community-based. So I come to this work as a family member and as a parent advocate, and with also the realization that the youth voice is as important in terms of making systems work. Youth and young adults and their families are the people that should define what a crisis is. Indeed, we've seen where the crisis can be determined by external entities like school professionals and others who in some situations feel that they should be able to directly contact a contracted system administrator or gatekeeper and make arrangements. But we are not in favor of that, because only the family knows, only the individual who's going through the crisis and their close loved ones know what the crisis is. So crisis is defined by the youth and family. When a parent calls for help, they're calling because they have reached a situation that they find difficult to manage without external support. And it takes an awful lot of courage and strength to acknowledge that I'm in a place where I, as a parent or caregiver, no longer feel that I have the capacity to respond effectively to what's going on in my family's life. So I think as providers, we all need to be sensitive to that. A crisis, as we define it, is when a caregiver or youth doesn't know what to do, is concerned about the next steps and needs additional supports, perhaps skills, perhaps resources, in order to sustain their family in the community, in school, and doing the things that are typical for that family. We often hear families say that they are overwhelmed. Overwhelmed. That's one of the words that I've heard in every call that I've received. They're overwhelmed, life has become unmanageable. And at that moment, what they need and want and deserve is a timely, non-judgmental response. This is a place where empathy and urgency must come together to be effective. And we have to meet families where they are, not where we think as professionals or as other service providers they should be, but where they actually are, with the goal of having the family define their vision and what stabilization and return to a place of homeostasis or regular life would be like for them. Our goal as a family support organization is to help families return to that life, that vision, as in the community as soon as possible, with additional connections that can sustain them beyond this particular intervention, beyond mobile response and stabilization, and not just help them survive, but help them to actually thrive, to develop the coping, resilience, connections. We've learned a lot about connections in the last couple of years, right? And the most important thing that we've learned is the value of those social connections. And that's where peer support comes in. It's in terms of being a unique relationship that's formed based on shared lived experiences and a mutual trust. So I think that's one of the key things, thriving at home, at school, and in the community. One other thing I'd like to say about the crisis and our response to that is that acute psychiatric disorders and suicide ideation or attempts are a place where 988 can be incredibly valuable. And we're so grateful to have had the opportunity to have our staff here in New Jersey at all the family support organizations trained in the Zero Suicide Initiative so that we can educate parents, professionals, and peers about these resources and how to utilize them as part of a crisis response system. I'd like to move on and talk a little bit more deeply about the role of peer support, which is where I've lived for the last almost 2 decades now. Ideally, peer support begins at the moment the caregiver calls for help. Right then, our goal is to build the caregiver's sense of self-efficacy. I can do this. In fact, one of our common mantras is, you don't have to do this alone, we're here for you. And as peer support staff and I hate to call us staff, but as peer support providers, we offer a unique blend of reassurance and information that comes from our lived experience and training that can be extremely helpful in crisis situations. It reduces parental anxiety. It instills hope and optimism by looking at someone who can say, hey, I've been there. I know what it's like to be in your space, and you can do this. So we say, you don't have to do this alone. We're here for you. Typically, peer support providers are not clinicians, but I have to say that many people come with various backgrounds that can be tremendously helpful to the team. Some of us are educators by training. Some of us are school bus drivers and crossing guards and lunchroom attendants who have tremendous insight into children and children's behavior, and as parents themselves can also bring incredible wealth to the teams. So they should be respected and valued as individuals who are equal to professionals on the team. What we do that's unique is provide supportive listening, guidance, education, and advocacy. And I can't overemphasize the importance of listening. I refer to it as the ministry of presence. Sometimes just being present and having someone listen to you is enough to get you over a difficult situation. And we hear that from parents over and over again. We wanted to be heard. We didn't feel heard. Finally, I've met somebody who gets it. The benefits that we offer may not be considered therapy, but they certainly have therapeutic value. They complement care management services that are offered by other members of the team. And as a formal member of child and family teams, peer support is a resource that not only benefits the families that we serve, but it also helps the team members to understand the youth and family voice and perspectives that must be heard throughout the engagement process and phase, and every subsequent stage of engagement with formal systems of care. So the way I see it is that youth and family voice is central. The caregiver defines the crisis along with the youth. And as Shane so eloquently pointed out, there are times when there are differences of opinions that have to be navigated there, but it's a family. And at the end of the day, I think most parents want what is best for themselves and their families. There are times when that's not always true. And in those situations, we want to be sure to honor and preserve the dignity that's our fundamental right as humans. Another important role of peer support is connecting youth and families to sustainable resources. You know, these systems are not meant to be lifelong partners. They're meant to be stabilization and help us to return to a typical normal life for us as we define it in our communities. One of the things that we pride ourselves in doing is helping families access services without needing to go back through the children's system of care or other formal services. And this is done primarily by fostering the development of peer support relationships, helping families to expand their network of supports. A lot of times parents will say, I don't have anybody that I can rely on or talk to about this because of shame and stigma. And so beginning to bring parents together who have similar experiences to talk about their journeys, to share resources and information that can be helpful, fosters a sense of community and belonging, which is another one of the key lessons that we've learned over the last several years, the importance of community and belonging. And from that grows the self-efficacy and the ability to cope with and be resilient, even if your situation does not change dramatically, how you respond to it can change. You learn new ways of being and coping. Family support partners provide connection to support groups and other resources in the community. Our work is primarily face-to-face, and I like to refer to it as high-tech and high-touch, because we not only utilize the virtues of technology to share information with families and with youth, but we also ensure that there's that human element, the frequent calls, the text messages, the check-ins, and the in-person support groups when they're possible. Our work is very strengths-based. We don't look at this as, we don't look for the deficits. We look first for the strengths that can be used to address the needs. And in all of our work, the central premise is that youth and families know what's best for them. And we want to elevate their voices and ensure that they are both heard at the tables where decisions are being made. It's truly the only way that we can effectively bring about healing and transformation in the lives of individuals that we are privileged to serve. Services, as Shane pointed out, must be culturally relatable. And I think of this as an opportunity for us to always be growing in the area of cultural humility, because we don't know how one defines their culture and what resonates with them may be different. So I come to this with a fair amount of humility based on lived experience and having some caregivers educate me that as a parent who is also a social worker, I didn't have the answers. So I'm forever grateful for that one visit that set me on the right path to learning and being humble and to exploring my own areas of internalized oppression that affected the way I viewed the world and viewed the people that I have the privilege of serving. Next, I'd like to just say that in terms of law enforcement, I think I came to this originally thinking, wow, you know, they could be potential partners, but it only took one experience, a real life experience, not an academic exercise, in our largest city in New Jersey, where I was in the home visiting, and a young man was having a crisis, and I was told to call 911. Well, I knew intuitively that that was the wrong thing, because if I had, he would have run, and the consequences could have been dire. So we want to emphasize in all of our work that while law enforcement can be beneficial at times, it is not the way to engage youth and families. It is not the way to engage youth and families when they're having an emotional, behavioral, or mental health crisis. We want to emphasize that the family and the youth must have a voice in when law enforcement is called. Again, they know best what's going to work and what can be dangerous. So we know that the outcome can be difficult or not favorable, to say the least, in some situations. So we also advocate for law enforcement to be trained. And I've even had the privilege of doing some of that work in our community. We want them to be trained to know about the resources that they can utilize, not to respond themselves, but they can tap into mobile response. They can tap into the family support organizations and other community resources in order to help families when they're called. So I think there's promising work being done in that area. The area of how do we partner effectively as family members with youth, with other members of the team, and with other social services providers. And I'm very optimistic and hopeful that as we continue to do this work, the continuum will evolve to a place where families and youth are really driving the system and the transformation that needs to take place. So thank you.
Thank you, Hazelyn. A couple of really big important points in there just around, the engagement strategies, the role of parents. And I just want to make sure that folks who are listening in recognize that when we talk about mobile response and stabilization, we are talking about a continuum. So this is a service and support for individuals who are, as young as 4, right? And really into young adulthood. So it's important to know that parents are going to play different roles in different places. So thank you, Hazelyn, for your comments. We have some questions in the chat we're going to get to in a little bit, but let's move on to Shamika. Shamika, you want to share your experiences at the state level and it really in implementation and sustainability of mobile?
Absolutely. Thank you, Liz. And again, to my colleagues, Shane and Hazel, amazing information and conversation. So I'm Shamika Williams. I'm the Director of Children, Youth, and Family Services at the Department of Mental Health and Substance Abuse Services. And I'm also a colleague of both Liz and Tim on the MRSS Learning Collaborative with the University of Connecticut. And so I'm happy to be here today. I want to talk around 4 different points. I want to talk about the sense of urgency. I want to talk about someone to respond, someone to connect, and I also want to talk about someone to support. When I talk about response, connect, and support, I'm really changing the language in a sense around how we provide support and services to families. Oftentimes, our language is really in a way that is not conducive to the ways our families communicate, talk. And so I really want to talk about respond, connecting, and supporting as three main topics. Well, let's talk about the sense of urgency. In the state of Oklahoma, I think many of us prior to COVID really felt a need to really develop a continuum of crisis care for kids and really specialize their crisis care services where it aided not just the young person, but was also inclusive of the family. In addition to that, all of us around the world had our dark experiences with COVID. When young people were diverted back to home, they were going to school from home, schools were shut down all over the country. Again, building a sense of anxiety and depression in a lot of our families and a lot of our young people across the nation. In addition to that, when we think, we often don't think about our smaller young people. Think about our babies who were born during the COVID times. As an example, babies who were born during COVID did not go out in public. Imagine having a young person, a newborn in your home for months and months. And the first time you take that newborn out to interface with other people or interface in a community setting like a Walmart. I mean, again, how traumatizing can that be? And so really when we're thinking about the state of our nation, pre-COVID, we were already in a space where crisis services need to be developed, not just for young people, but for families. Families needed a place to connect. Families needed a place in order to get help and support. And then during COVID, I mean, again, our kids were not able to hug and touch and love on one another. And of course, as an adult, that was very difficult for me. So I can imagine how much more difficult it was for our young people. And so really thinking about the sense of urgency that's taking place across the nation for crisis services for kids and adults, but primarily focusing on kids and the way that kids services should be designed completely different. Kids are not little adults. Kids are kids. They're young people. And so let's talk about that. Early, Hazel and Shane talked about the response. And so I really want to talk about someone to respond. When in fact a family or a young person is in crisis from the perspective of a parent, and I'm a parent as well, when we want help now. And for the most part, a lot of emergency room utilization was used across the nation because parents knew if in fact they needed help, the first place that they could go to get that help was an emergency room. No different than you go to an emergency room to get help for your physical ailment. If you break an arm, or if you're having signs from diabetes, or if you're having heart palpitations, most people go to the emergency room. And that was no different when it came to mental health. Parents were taking their young people to the emergency rooms for help. In addition to that, we've seen signs across the nation when parents were in need of help, and say, for instance, your young people are in psychiatric distress, parents will call 911. Who do you call when you have an emergency? 911. And so what we're talking about is really how do we divert away from those system structures and create infrastructure within our states or within our communities to support those young people and to support those young people in the context of a family. This is not an individualized situation where we're working with young people and we don't consider the caregiver, or we don't consider the parents of those kids as a part of practice. What we know is through COVID, when parents were in distress, kids were in distress. And what we also know, when kids are in distress, parents are in distress. So again, that separation is not a separation that we want to make when we talk about providing crisis care and crisis support for kids and kids who need us, or families who need us. That is part of the reason why it's important for us in the state of Oklahoma to utilize the language mobile response and stabilization, and not children's crisis. Okay, because when we talk about crisis in the context of a family, that language is a little different. Because for me as a parent, a crisis is defined by me. What I see as a crisis is a crisis. So if I'm in a situation where, it's unfortunate, my young person, whether they're running away, whether I can't get them to go to bed, I can't get them to, go to school, or if I'm in a situation where I'm just not sure what's going on with the reactions as it relates to his behaviors. There are things that oftentimes families don't have the range of resources in order to connect, in order to stabilize the situation. And oftentimes, imagine if a family is in a situation where they're not getting their basic needs met. Again, that has the ability to impact the young person. So that can definitely be a situation of a crisis to a family. And so for the most part, in an MRSS system, families should be able to define the crisis situation. Okay, I think that's important. And when we're talking about someone to respond, again, imagine calling 911. Well, some of us have experience of calling 911, and it takes hours and hours and hours and hours before you get a response, before IMSA comes or before the police department comes. Again, what do? You get in your car and you go to the nearest emergency room. And so again, someone to respond is really important, that we have not just the response system that we can call, and the call centers or the people who are answering the phone are responsive to our needs. They're asking questions. They're listening to us in a way where we're clearly able to articulate what our needs are. In addition to that, really creating an opportunity to utilize supporting factors that you would not necessarily see in emergency response system. As an example, we've had several mentionings of law enforcement, and the importance that it is important that we understand that law enforcement has a goal of providing a sense of safety, not mental health professionals. Okay. I think that's really important, because when we talk about someone respond and we have a young person in a family that is needing a response, we need to send them the most appropriately qualified professional in order to make that response. And so really looking at ways to to separate the utilization of law enforcement so they can focus on safety factors and use mental health professionals, care coordinators, family support providers, wraparound providers, therapists in order to develop this response system to meet the needs of children, youth, and families. In addition to that, I think it's also important, I heard a story from a family member not long ago whose crisis situation ended in a tragedy. And so considering that this was a situation that did involve law enforcement, and many situations involving law enforcement don't always end in tragedy. So let me say that, but this particular situation did. And in this case, the parent was an active parent and was capable of maintaining the safety of her child, and asked that law enforcement not be engaged as a part of the response. But because, again, the call center felt like it was a safety issue, 911 was available, and the situation didn't go in the best direction. And I say that because I think it's important for us to ask parents, what is it that you want? Do you want police involved in this response? And give them the option to make that determination and determine if this is a response that should result in the utilization of law enforcement. It's also important when we think about our response, we think about that sense of urgency. Collectively in our MRSS system, we have we want responses to happen no longer than 60 minutes. We want our providers to reach our families within 60 minutes. Of course, Oklahoma is a rural state, so 60 minutes seems like a long time, but drive time can be quite difficult for some. But for the most case, we want responses to happen as quickly as possible when in fact a parent says, yes, I want someone to come out now. Okay. We also understand that due to the nature of the situation, sometimes parents want delayed response, but it is important for systems to consider face-to-face response as the only type of response when working with children, youth, and families. The reason why that's important is because as quickly as possible that we can respond, as early as possible as we can respond, we can really look at preventing young people from going into higher levels of care or from escalating their behaviors to a point where they're in out of school or out of home types of placement. And so the quicker the response, the better the response, and then the appropriateness of the response. I mean, I think that states and systems should really look at the nature of how response are made. As an example, here in the state of Oklahoma, we believe that in many cases, families have the ability to maintain some level of safety with their kids. And so what we do is we respond with peer support individual. We respond with family support providers. We respond with case management level staff to do that work around diversion, to do that work around de-escalation. We know that there are times when kids need to be assessed and they need a crisis intervention services in order to make those determinations if there's a need for higher levels of care. And so really building your infrastructure in a way that ultimately there is a level of support. Peer supports are really great and amazing to really talk and work with parents when they're in crisis. And they're also great and amazing to talk with young people, again, when they're in crisis, and really look for opportunities to divert or to de-escalate those situations. It's also important to think about the connections. I think that in our MRSS, and I talk about our MRSS Learning Collaborative, because again, that is the foundational structure from my perspective around how we care for kids and families, not just in the state of Oklahoma, but how we should care for those kids and families across the nation. We talk about someone to connect. The important thing to think about when we're talking about someone to connect is really not just about connecting with that crisis, that mobile responder. It's really about making connections in the community, making the connections in places and spaces where young people and families have connected to. So as an example, really training and teaching school professionals and school teachers on how to handle young people when they're in crisis, who to call, who's the most appropriate to call, not calling 911, but calling the mobile response and stabilization team as a point of the effort. Also training your faith-based entities and other civic groups around mental health. I mean, youth mental health first aid is a great example of a training that can be provided in the community to non-professional folks around mental health and how to understand, but this not just how to understand, but also who to connect with when in fact those things are important. And I think it's also important because I don't want to take law enforcement out of the equation. In the state of Oklahoma, we have a robust relationship with our law enforcement. We feel like our law enforcement, again, have a job to do. And that job is not a mental health That job is not mental health, but oftentimes they are interfaced with individuals in the community who have mental illness. So in the state of Oklahoma, we've deployed iPads throughout the states to our law enforcement officers for the purpose of those law enforcement officers having a way to connect to a mental health professional when in fact they go out on a call or they're out in the community and they come across a young person who needs some mental health help. Our goal is that if in fact we can have our law enforcement equipped with this iPad, the chances that they will have to do any harm, and let's not say do any harm, but work outside of their expertise, it's limited. We also provide what we call CIT training to all of our law enforcement officers. So we offer this training on a monthly basis where law enforcement officers can come in and really help get a better understanding of mental health issues as it relates to children and adults. I think it's really law enforcement officers shouldn't have to be mental health professionals. And so again, it's important to provide them with the training, but then also the tools when in fact they do come in contact with somebody who really needs our help, and how to transition that help to a mental health professional. So again, those young people can maintain at the highest level of safety and support that they need. And so someone to connect is really important. I think it's also important not just for us to have a mobile response and stabilization system that provides crisis work. We ought to really create and look at those types of partnerships within the community, creating pathways of intervention, creating pathways that creates access for kids, and kids and families don't have to get to a crisis state before they can get to help. And so it's really important to create those pathways. And what are those pathways? They're really relationships where you've worked out a specific roadmap of how to help kids who may be experiencing trauma, mental health, or even substance abuse issues. So really creating those pathways in the community, pathways and connections. And then also, I talked a lot about the utilization of technology in the state of Oklahoma and how we utilize technology as a way to support not just our law enforcement, but our children, youth, and families across the state. It is also important for states to really consider how to build that system of support. The system of support is not just a system of support after the crisis. It really can be a system of support pre-crisis, where outpatient mental health treatment service, outpatient supports, recovery groups can be offered in your communities across your state, giving families an avenue to get the help that they need. I say this quite often as a parent. As a parent, I kind of go back to what Liz Manley said early on. It's really about at that particular time what I'm going through. And I want people just go. I want people to go. And when you get there, then offer the support and help. Connect with the family to see what are the resources and supports that they need in order to be effective. In addition to that, I also think that states and communities should really allow parents, caregivers, and family members to be a part of the conversation about mobile response and stabilization. There's nothing worse than building a system. I mean, as an example, I can't imagine walking into my doctor's office being a plus size woman and he telling me what I have to eat in order to lose weight. There's no way that he's going to have me eating broccoli every day, 5 days a week. So as an example, why are we creating a system for families and not with families? We should create systems of support. We should create systems that allow connection. We should create systems that allow us to be responsive to youth and families, with youth and with families at the table. So if you want to know if your system is working right, again, a lot of us put out multiple surveys throughout the years. Bring those families that are receiving your services to the table and ask those questions, and begin to create an infrastructure and a framework that's really about them and how, in fact, they want to receive services and how they want to receive supports, and allow them to provide you with that feedback as you guys are building your mobile response and stabilization system for your children, youth, and families in your states, in your communities, and in your jurisdictions. So Liz, I'm going to shut it down there and hand it back over to you.
Thank you, Shamika. And I just want to elevate one thing that you said that I think is so incredibly important. And that is that, you said so many things that are important, but I just want to highlight that the word crisis isn't really helpful when you're developing a system, because professionals define crisis very differently than young people and families do. And it's really important that we get into the habit of just going, just go find out, see what's happening. And what we learned in our 20 years experience, over 20 years experience in New Jersey, is that there was never a time we went where we shouldn't have. So I'm going to hand to Tim Marshall. Tim, you have, I know, lots of words of wisdom there.
Great. So good afternoon. And it's been an honor to follow you all in front of me. And it's amazing. None of us compared notes, but how are the themes you'll hear over and over are pretty consistent here. So I was asked to talk about kind of lessons learned from Connecticut. Connecticut, we're a little bit more mature. We've had 13 years of our MRSS system, and focusing on what was the most useful lessons learned for implementation of sustainability. And I have 4 of those areas also, and you'll hear some consistent messaging in those 4 areas. But I also would want to say that these also are really important in both the design and planning phase. So it's not just, just the implementation of sustainability, but my 4. Number 1, data, data, data. And I'll talk a little bit more about that. Number 2, engage your formal system partners in a deliberate and intentional way. And I'll say a little bit more about that, in particular, some of the more important partners that you should engage. Number 3, and I hope you hear this over and over, children, youth, young adults, and families is where it's at, period, exclamation point. And we'll go through that a little bit. And the 4th is outreach and education is a forever commitment on the MRSS system. So those are the 4. So the first, data, data, data. The first thing, if possible, is to have a similar uniform data platform, if possible. If not, do the best you can for the data systems to talk directly to one another for the most efficient use of time and resources. So for example, in Connecticut, our data platform begins at the call, and the call center, contact center now, because they take more than calls, they can pre-fill all of the information into the electronic health record. We don't use that term in Connecticut, but into our data platform. The caller then is stating their presenting issue, and that is automatically it's automatically put through to the local provider who will be responding. The message that we gave in Connecticut and what we did is to purchase face-to-face assessment. So we did not purchase a telephonic triage process. So our contact center is essentially just taking the information for what the presenting problem is. They restate the presenting problem to the clinician at the local level. And then all of the demographic information that had to be loaded into the data system is already passed forward in real time. So that is really efficient. So the receiving clinician is literally just finding tuning, location where they are, maybe in an apartment building, or, is there animals, and any other last minute questions, but they're not revisiting the purpose of the call. They're on the way is as fast as they can. So the data system itself is also really useful. In the data, really developing your case at the system level, which is one of the most difficult things to do, is really important. So being able to collect data that tells funders, legislators, that you've diverted a number of situations from either emergency departments or inpatient care, which are some of the most costly and most restrictive levels of treatment. You build a case by being able to collect that data out of the gate. In Connecticut, we did that. We didn't even know how successful we were being at that, but we built it into the system. So that's really primary, and you can tell your story is really important. And then the other 2 pieces is at the provider level, being sure that the data you're collecting is able to be used for high quality care management. And so we are made sure that the providers have that same access in real time. They can run real-time reports from the same data system at any time. And it's the same data system that we use at the state to look at each provider separately, each site separately. We have 6 main regions in the state, 6 primary contractors, and there's 14 sites. We know exactly the quality of every piece of every site in the state by site, by provider, and then all the way up to the statewide system. So this notion of having good, strong, robust data so you can be reflecting upon how well the system is doing is really important. So number two, engage your formal systems partners in a planful and deliberate way is really important. I would lead with the emergency departments. They need to be educated on what your best practices are, what the primary purposes of your use of mobile response system is about. In particular, the parts where you really get a lot of collaborative and cooperation is emergency departments, to be very direct about it, were developed for crisis medical conditions. That's what they do best. They're not very useful frequently, even when they're at their best for doing primary behavioral health intervention, particularly if a kid's in crisis. Additionally, emergency departments are really potentially very traumatizing to kids. And any particular day, they can witness something that's really not good for them and just adds to their behavioral health condition. So engaging the emergency department about the quality of the service that you're planning to implement, that you have implemented, that you are implementing is really important. And to say to them directly, we're trying to divert kids from the behavioral health system from not coming into the front door here. So that's really important. Likewise, juvenile justice, child welfare, all those partners are really, really important. And they're really important also potentially for your funding to be able to support the work that you're doing to add to third-party reimbursement, Medicaid, commercial insurances, or any other way that you might be funding. And then finally, the law enforcement. In Connecticut, we do use law enforcement in a very limited capacity, but when we do, we will use the team approach first. If we have to, and it's only a handful of times a year, it's really as a presence in the driveway, if you will, or out in front of the building, and they don't get out unless it's absolutely necessary. And it's incredibly rare that we've ever even needed law enforcement at the door in Connecticut. But the main purpose about engaging them is to do the same, is to basically acknowledge, again, what you have to offer to them so they become a referring agent and helpful to support the work that you're doing. And our experience in Connecticut is really earning your credibility. You know, if you do good work and law enforcement knows it, they're going to use you. And so it's really educating and outreaching to law enforcement in a very deliberate and specific way, and how you can be helpful to one another in your various roles. Number three, children, youth, and young adults and families is where it's at. And the primary formal system partner I left out of the previous one is because I was going to add it here, and I would add schools. So again, particularly the part where youth and families and young adults get left out is in the design and planning phase. Probably the most important part. And in fact, if you talk to many family members, including the ones we have on, they'll tell you that they're frequently invited to the table after implementation and say, now what do you think? And it's like, wait a minute, we missed all the steps of planning because we could have helped you with some important design features that would have had us at the table much more routinely and frequently. So that's really, really important. And the part I wanted to say about schools, because so much of the of children and youth, especially those 18 or younger, spend so much time at schools. You got to be very, very deliberate and engaging in your schools. You have to go out formally and again, educate them and really help them understand, especially particularly when there's activities across the country now, like AWARE, where schools are developing comprehensive mental health, student mental health packages in the school system, is to help them understand how mobile response can blend right into any student mental health initiative, from school climate activities to SEL, right up to the kid who is suicidal, and how you can be supportive and helpful to them. So that's really, really important to engage directly, fundamentally, and intentionally with the partners in schools. And then finally, my outreach and education is a forever commitment. And again, I'm going to say this in particular, after you've designed and early in your planning, be as early as you possibly can get during or before implementation, is to educate the community, educate the formal system partners on what the best practice it is that you hope to need to respond to, what you're hoping to develop as your best practice. In particular, when your state or your county is struggling with a medical model approach or a law enforcement approach to crises, educating the consumer, the family, the youth peer support to help them get the word out about what you're trying to do can help you save your time in helping trying to convince other professionals about trying to do that. Same with kind of the medical model child and adolescent psychiatrist who thinks every kid in crisis needs to go into an inpatient unit. It's really important to help educate them in terms of what the practice is and how you can support and maintain kids in the community, which is a much healthier, less traumatizing situation than ever going to any inpatient unit. People don't realize the inpatient unit is like the highest level of care for acute need, but in and of itself can be terribly traumatizing and add and compound the behavioral need that is already there. It's the last place on the earth any of us want our kids to go, and should be that of strangers also. So those are my 4. Data, data, data. Make sure you engage your partners systemically and deliberately. Children, youth, and families need to be engaged. Young adults need to get engaged every step of the way, all the way through sustainability. Be using them to check on your quality assurance. In Connecticut, we require each provider to develop an annual performance improvement plan, and they have to look at their data internally. And their data internally is supposed to have a team on it who has representatives who they've served in the community of youth and young adults and family members. And then finally, that outreach and education is forever. Thank you, Liz.
Thank you, Tim. This has been such a really robust review of all the things that we have learned around innovations and sustainability and some of the work that has happened across the country, for sure. There's a couple questions in the chat. I want to get to them first, and then I certainly have a couple of things I would like you guys to sort of focus attention on. But let's start with the first question that I think is an important one. Let's start with 988. And the question around 988 is, what do we think of it? So let me lay some of the groundwork. I think folks will have a bit to say about it. We think, at least my experience, my thought is 988 is a real opportunity, and we're excited about it. But we're also, because we work in the children's space, we're worried. We're very worried. We're worried about young adults, by the way. We're worried about how young adults perceive 988, how they're going to use 988, and some of the tools that Shane talked about earlier around things like geomapping and what to do when young people are calling and asking for help, but not kind of the help that professionals think they should have. We're also worried about 988 because in the world of children, those, we talked about that continuum. When we talk about children and the parent really taking the lead in reaching out and asking for help, their worry is that in a world that the professionals are defining the crisis, in a sense, that our parents, our caregivers are not going to be heard in the way that we think they should. And a just go model is sometimes really challenging within the model of 988. We believe 100% of the time a parent calls, request assistance, that the team should go. And that is not really what's happening in the 988 world as it's currently designed. We also know it's early implementation in 988. So what we see as what's happening now versus what potentially could be happening down the road are 2 different things. And so our responsibility is to help folks understand the real worry, missed opportunities, and every missed opportunity for a child is worrisome of what happens later for them. One other thing I want to say is that when we think about this work, we think about children not in a 7-day model or a 30-day model. We're thinking about what happens today impacts in what happens later. And if we really want to understand the impact of a service support like mobile response and stabilization, we don't just look at, did they not go to the emergency department We look at, did they not go to the emergency department, get what they need? Did they end up in residential down the line, right? Did they end up in other higher intensities of service down the line? Or were they able to remain in their own schools, graduate on time? Were they able to access supports and services at the time they needed for the duration they needed, recognizing that that's an ebb and flow kind of world? So that's so I'm just going to start that conversation. I'm going to open it up to whoever else wants to go next.
Well, I'll go. I think Shamika, you and I can probably contrast each other. I'll go from a little bit of a different perspective, just because in Connecticut we've had some really good early success in implementation of 988. And so I'll give this because I know a number of states are really struggling with this. So I feel like it's important to try to get out that it is in fact possible. So again, Connecticut is a small state, so that we have going for itself. In fact, I will often recommend to other states that you think about Connecticut as a county-wide kind of system. But essentially, we have our one main call center. We had two, and we merged back into one. And so our 988 call center is the same call center that we had been using for both the child mobile response system, as well as the adult mobile response system, as well as the adult warm line, a call line that people could call in just to talk. It was never anybody to respond, but it was always somebody to talk to. So we predated the implementation of 988, where we already had trained call and now contact specialists who knew exactly if a caller called in and they were adult in crisis, how to triage that and send it into the adult provider at the local level, dispatch if needed on the adult side. The same call specialists are trained on the child mobile response system. And in that system, it's an automatic just go face-to-face unless the family absolutely doesn't want it. And then the action line, which is the adult call center line, is also there and for people just to talk. So those are the three lines are there. So when 988 rolled out and we went live, we had, like every other state, the planning grant and then the implementation phase that we've been working on here. We worked really, really hard to funnel all those calls and train all staff in all things. So there's no transfers for anyone, and all call center, contact center staff. Sorry, I'm still getting used to the switch because it used to only be calls, but it's now the chat and text, which is coming in Connecticut, but is not here. But essentially that notion that anyone can handle anything. So they may stay on the call with a 988 caller, but if the 988 caller is coming as an adult and there's a potential useful intervention with a mobile response, they'll triage that through the local mobile responder, and they will often go out and see that person. The adult system does more telephonic or telehealth than the adult system, than the child system does. So they might handle that telephonically or through a virtual meeting. But on the child side, then they're just automatically going and responding. So our call to answer rate is very, very fast and very efficient in Connecticut. The high percentage of calls we're handling in Connecticut at 988 and we're handling ourselves is like 98%. It's really, really high. And then the satisfaction of those callers is very, very high, and they're getting direct and they're not being transferred from one system to another. So I give you that example because I understand many places are bigger. They might have 3, 4, might have 10, 20 call centers. The most important thing is linking the 988 folks to the mobile, I would say lifespan mobile, both on the MRS side, on the adult and the child, and do your best. And you have to engage law enforcement, and you have to engage all the PSAPs. Connecticut, we did this very thorough education and outreach to all the PSAPs in the state in terms of the whole process playing out, but also what both the adult mobile response system and the child response system can do and help with. So I just wanted to put a little bit of an optimistic piece there.
Well, thank you for that, Tim. I definitely think that Connecticut has done an amazing job when you're looking at that someone to connect to, because merging the call centers in a way that you guys have done has been great. We'll continue to work on that merger here in the state of Oklahoma. We still have our MRSS line, but a lot of our calls are coming in through 988, and of course 988 is an amazing thing. It has been a huge success here in the state of Oklahoma. But there's a couple things that I want to mention, Liz, particular things that are on the minds of a lot of our children's directors across the nation. I think that oftentimes when states build a crisis system, these states build a crisis system, there's a tendency to really build higher levels of care, really looking at, increasing the number of beds in acute types of settings, increasing the number of increasing access to more of those out of home, out of community types of placement. Those of us who are really grounded in the systems of care values and principles believe that states should really focus on the support system, the outpatient behavioral health system, and really focus on making sure that when kids and families are in crisis, they have a place to connect to for those stabilization efforts. But not only just for crisis and stabilization, that they have the ability to make those connections pre-crisis. And so again, building a robust, acute type of system that actually that can come along with a new launch around crisis care services is important, but it's also important for states to build systems where they have the ability to connect these families for the stabilization or for the community supports that they need. And I want to piggyback off of something Tim said, and then I'll turn it back over, Liz. I think the one thing that we have to think about, there's only one placement that I'm familiar with where kids can go into a placement and be separated from their parents, and that's in a mental health crisis system. When you look at acute psychiatric emergencies, oftentimes kids are separated from their families. When you look at the medical model, parents never have to leave the ICU room or the emergency room when in fact their kids have a medical emergency, but it's often different when it comes to a psychiatric emergency. And I think that's something for us to think about, really thinking about changing the way we model and changing the way that we provide higher levels of care as it relates to mental health crisis.
Thank you, Shamika. Thank you. I want to make one other point, and then we're going to move on to the next question. And my point is that the children's system, right, that is organized for children, youth, and young adults really needs to recognize that we need multiple supports, right? And we're not just talking about young people, we're talking about families as well. And it's important for us to get there early, to get there in ways that can be helpful and supportive to the young person and to their family. And that the goal for us, right, is not just to, we have like a bigger responsibility because it's the first touch many families ever make. It's a first phone call, first touch in a public system where they call, they ask for help, and the experience is going to drive their experience and their thoughts about the system across their lifetime. It is imperative that we get it right, and we really have to work on a direction to get it right. 988 can be a tool for that in the long term, in the moment if there's worry about what that looks like. I just want to move on to there was another important comment or question that came up in the chat. And then, by the way, we're going to get to peer support. So I'm just going to put Shane and Hazelyn on notice that we're going to get to peer support in just a second, because I want to make sure we address that as well. But there was a question about whether or not a child needed to actually have complexity in order to use a crisis system. And the truth of the matter is that mobile response and stabilization is designed as a public health approach to get there when the adults in a child, like in a 3 and 4 and 5-year-old's life, is beginning to worry, right? Why would we wait until they're 10, right? Why would we wait for for the system to activate when the adults in a child's life are beginning to worry? I also want to say that that system should activate when a young person needs it. When the young person picks up the phone, we should not be saying, "Oh, sorry, yeah, we can't really help you," until the chair is flown across the room, right? This is not how mobile response and stabilization is designed. Because the other thing that we know is that people wait to call in the first place, right? And so we want to make sure that when they call, that we're going to be attentive to that call, we're going to get to that call, and we're going to address it. We also know that when we get there, things are almost always more complicated than they're communicated over the phone. And so it's really important that we design the system as a public health approach that does not require means testing or, a requirement of having Medicaid in order to access it, to be part of a child welfare system to access it, a juvenile justice system to access it. We want to make sure that we can access these services and supports in the upfront to prevent the use of systems like child welfare, juvenile justice, the use of emergency departments and inpatient care as an example. So I just put that out there. If you want more further information, we're happy to share that. Melissa did share some resources in the chat around that. It's really important part of the conversation. Okay, this is really important. So we're gonna land on peer support. Hazelyn, you had 2 questions in the chat, and Shane, you had one around peer support. So I'm gonna let you guys figure out who goes first. How's that? All right, I'll pick. Shane, go first.
Okay. So just looking at my notes, because I was obviously typing some thoughts away as I was seeing comments happen. In terms of like if peer support will continue to happen post like crisis response service involvement, right? I can't say specifically what that looks like across each state that these services exist in, but I would say ideally they should, right? And at the very least, even if there needs to be a handoff to a different type of peer support program or resource, being that bridge to connect them, right? So that it's not just this like cold sort of good luck with the rest of your life. I know I'm somebody that like I've struggled with that, right? I kind of go back into my community, just sort of like swimming aimlessly, I guess. So really connecting folks to those ongoing resources and really gauging what peer supports you have within your communities. And then another thing I really appreciate that somebody mentioned this too, the importance of having, and this is true for youth peer support workers too, but having peer workers employed by peer run organizations, right? And I think that a big importance of that is that there's a lot of role confusion when it comes to peer support, and there isn't like I think that there are like national guidelines and best practices in terms of like how to define the role, but there is no like written in stone, this is how it needs to work, these are the values you need to hold. So that can kind of get misinterpreted, misconstrued, and folks in sort of those siloed single peer roles around more like traditional service teams, like they might, there can exist some role confusion. They can end up contributing to or doing work that's outside of their role, right? So I think really just making sure that it is wholeheartedly peer support through and through, and aligned with all of the values and ethics that we hold really important. It would be hiring or partnering with an organization that is through and through peer, if that makes sense. So that's
It
me.
makes perfect sense. And I just also agree, right? And I know Hazelyn's going to agree with that. But the other part of this work is not even just the peer-to-peer day-to-day holding hands, but also the role peer support partners play in policy and policy decisions and advocacy that can get really confusing in other places. But Hazelyn, I'm sure you're going to touch on this. So I'm going to
Absolutely. So we know that from the years of experience that having the independent family voice is absolutely critical to informing policy and best practice. We know that when individuals are either hired as a single peer support person within an organization or even a team, there can be the role confusion that Shane spoke about, but also there tends to be a shift in the driver of the conversations, where peer support can become an adjunct to the clinical staff and the care management staff. And so we want to guard against that kind of dilution of the role and the value of peer support by maintaining that independent family voice for some of the reasons that Liz talked about. Another important reason is that we too need to have and thrive in a community of practice. And when you are isolated in an organization that does not share the same values and principles around peer support and the primacy of the family and youth voice, it is easy to migrate from those very values that form this movement which is deeply rooted in the philosophy that there should be nothing about us without us. Nothing about us without us. And lastly, I'd like to say that in terms of the independent family voice, I think there's a role for families to play throughout the evolution of a service delivery system, from being co-designers. And as one of our board members who is a dad, a granddad, and now a great-granddad says, he wants to be at the big people's table, not at the kiddie table at Thanksgiving. He wants to be where the decisions are made and to be co-creators of the services. And that's hard to do when you're embedded in an institution that embodies the medical model, or even a model that says there's this hierarchical system or way of thinking about who gets to make decisions. And often families are not part of that. So definitely we come down on the side of wanting to see independent family voice preserved, supported, and have capacity built around that. Yeah, the other thing is in terms of, I think there was another question about how long services are available to mobile. Should I go there, Liz?
Yeah, if you could, that'd be great.
Okay, available to families that receive mobile response and stabilization. So a couple of things about that. The way things are structured here in New Jersey, a family is not automatically connected to mobile response at the time that they call for help. That's really up to each local family support organization in New Jersey to develop that relationship with their local system partners. So we offer 4 different levels of service, or 4 products or services, if you will. One is the one-to-one peer support that's designed for those youth and families that are receiving care management services. But then there are a whole range of other things that can be beneficial and help to keep families safe, at home, in school, and thriving in their communities, like our Warm Line, which is an information and referral service that's available to anyone to call and say, help, I'm having an issue with school, help, services are about to end and I don't feel that I know what to do, help, my child is off the hook and I have my own health issues, my own challenges, so we can work with them. And that does not require even a call to the contracted system administrator or any other entity. That's just something that's out there. We educate our partners through the schools, through faith-based organizations, through other parent-run organizations, through PTAs, etc. And one other point is pediatricians. They're incredibly important. And we have begun, again, reaching out to our pediatricians in our communities to let them know that we are here and we can provide those warm line services to connect families. In terms of mobile response, that's one of the things we can offer. And the other is Youth Partnership, which is a movement of young people that helps them to develop peer relationships, self-advocacy skills, and leadership within the community to inform policy and practice. And then finally is our support groups and workshops. All of those things are available to families in the community without having to pay or having to access anything. It's a matter of building those connections so that people in the community, stakeholders in the community, know that these resources are available and they are as long as you need them to be or as long as you want them to be.
Thank you, Hazelyn. There was one more question in the chat I want to make sure that we touch on, and that is, how do we know that the interventions around mobile, and mobile response are impactful in diverting from inpatient and from. So I wanted to direct, first of all, that there is some information that was posted in the chat that could be helpful in organizing. But I also wanted, Tim, if you could just take a second to talk about some of the data work that you've done in Connecticut, I think would be helpful in folks understanding what work has been done already.
Sure. So I think one of the things is to demonstrate your return on investment. One of the foundational pieces of work you can do is you can take what your average cost of inpatient hospitalization is per day, what your average length of stay is, and then your average cost for your typical mobile response, an episode of care. which is what we did in Connecticut. And then we developed in this education outreach of emergency departments, we get direct referrals. The number one callers in Connecticut are schools, and then families. That used to be families and schools. That flip-flop when we went to a required MOA with all schools. And the third is emergency departments. And emergency departments, particularly when they're backed up, they have an ability to call mobile response and have them come and assess the kid and see if they can get them out of the emergency department and back into the community. And so when they call us, they have an ability to tell us whether they believe this is what we refer to as an inpatient diversion. So we literally count that, we educate them on how they could refer that. And so each year we have X number of calls. Now that is the least smallest number, if you will. So we run between 650, 700 of those annually. So if you take that and you just say that those calls, only those calls are being diverted from inpatient, you can easily do a math that leads you to what your return on investment. And in Connecticut, we're averaging about $5.5 to $6 million savings every year there. We know that that's the most conservative number because that's only the ones that they're most comfortable. We know that there's a whole bunch of kids we're getting to before they get to the ED. And we know that there's a whole bunch of kids who are coming out of the ED who weren't officially registered that way, if you will. So I think it's really important that you figure out that kind of measurement system in some fashion. So that's just one way to do it. There's other ways to do it. So that's really helpful for stating your case and telling your story.
Thank you, Tim. Hey, listen, this has been a really powerful way to end this series. And I can't begin to tell you how grateful I am that all of you agreed to join me today and really lifting up mobile response and stabilization, the importance of it in customization specifically for children, youth, families, and young adults. And for all of you who have joined us today and been joining us on this journey, we truly appreciate you tuning in and hearing what we have to say on what we think is one really transformational, I would even not call it a service, I would call it a transformational tool if you're interested in really changing the dynamics for young people. It's really, really important. So thank you again. I appreciate it. And I hope to see you all soon. Take care.
Thanks. Bye-bye.
Thank you for joining this month's Learning Community session. Please take a few moments to complete the evaluation for this session using the following link being posted in the chat. We will be providing a certificate of attendance after completion of each session offered throughout the entire Learning Community series. Please make sure that you are registered with the same name that you used to log into each session so that we can confirm your attendance and the total time you were a part of each session. Please allow up to 10 business days for your certificate of attendance to become available in the Innovations LMS. Any presentations, resources, and recordings will be made available to you within the Innovations LMS. Once you are registered for the Learning Community, you will have access to all the upcoming and previously recorded sessions. Thank you for joining us, and we look forward to you joining us for future learning opportunities.